before we talk about the long-term potential health impacts that COVID, long COVID, cardiovascular complications of COVID, neurovascular complications of COVID are causing, really to drill it down for the people that are listening, you have to understand what's going on in the body. And I just want to pick up and just expand for a few seconds on everything that Graham has said about the effect of COVID being predominantly a vascular disease. Now, we know from researchers like Amy Prohl, they're doing a lot of work with viral persistence, and that's not my area of expertise, but one of the things I'm looking at is the host response to infection. And there's quite a lot of evidence now from researchers like Doug Kell, Rizia Pretorius, Akiko Awasaki, Dave Petrino, lots of others, that the host response to infection is involved heavily in what's going on. And really what we think is causing cardiovascular complications and long COVID is the fact that COVID is damaging the blood vessels. Now, I see that Professor Altman's on the call here, so he can correct me if my rudimentary immunology is wrong. But my understanding certainly is that in the post-COVID condition, there can be a maladaptive innate and acquired immune response to SARS-CoV-2 infection. You can get non-classical monocytes, you can get chronically stimulated T cells. The immune system can become chronically stimulated. It can release pro-inflammatory mediators called cytokines. And so you can get this state of chronic inflammation in the bloodstream. And what that can do is can actually damage the inner lining of the blood vessels, as Graham has talked about, in the lungs, but we can see this in other parts of the body as well. And the inner lining of the blood vessels are called the endothelium. That's the inner protective layer. And when that becomes inflamed, it's called endothelitis. Now, several things happen when you get an endothelitis or endothelial damage or endothelial dysfunction. They're all kind of similar descriptions of a similar process. One of the first things that happens is the platelet molecules that are involved in clotting become hyperactivated, and then that in turn can trigger the coagulation cascade. So you can get clots forming. Now, if you get large clots forming and they travel to the lungs, you can get something called a pulmonary emboli or pulmonary infarction. If you get large clots traveling to the heart, you get a heart attack. If you get large clots traveling to the brain, you get a stroke. But what we're also seeing in individuals who've been infected with SARS-CoV-2, particularly in those with long COVID, but also in people who've had COVID and clinically recovered. And this is some work from our ongoing UK microclots trial that's been run by my colleague Caroline Dalton, is that you get lots and lots of little microclots. And these are not normal clots because in the presence of spike protein, the fibrin molecule that's involved in the clotting process becomes misfolded into an amyloid formation, and it also traps inflammatory molecules and other molecules involved in fibrinolysis, clot breakdown, inside it. And so you end up with a situation where you have lots and lots of little microclots that don't break down, or the body struggles to break them down. Now, we're seeing that in recovered COVID patients, and we're also seeing it in long COVID. It appears to be more in long COVID. And what we think may be happening is that when you make too many of these little microclots, they're becoming sequestered or stuck in the little capillary vascular beds. You have millions of little capillaries in your organs and obstructing the blood flow. And that may account for a lot of the symptoms of long COVID, but also there's inflammation in the capillaries themselves. And so if the endothelial lining layer of the capillaries, which are not as well protected as the bigger blood vessels, become disrupted, those inflammatory molecules can escape into the solid organs and cause organ damage. And we've seen in certain studies that there's evidence of neuroinflammation in the brains, there's evidence of inflammation in the heart with myocarditis. And that in itself is slightly concerning. And what I'm showing here is just some examples of this. So these are hyperactivated platelets compared to relatively normal looking ones. These are what microclots look like compared to a normal control that has, hardly any. And these are little shards of torn endothelium because the endothelium is inflamed and it's kind of been ripped off and it's floating around in the bloodstream, and you can see it under immunofluorescent microscopy. And here are the lungs of somebody who's got very damaged small blood vessels after having COVID. But looking as a cardiologist, my big concern is the cardiovascular effects. And I'm not going to go through all of these, but to answer the question, is there long-term outcome damage in other organs? The answer is Absolutely, yes, and the evidence is already there. This is a study out of America looking at 12 million people, over 153,000, showing that there was significant increased risk of heart attack, heart failure, and other cardiovascular complications. Now, this patients were followed up for 12 months, and these risks were pertinent for up to 12 months. This related mainly to Delta COVID and some Alpha patients. We don't know if it's quite as bad with Omicron, but it may well be. Now, it was a slightly older cohort, but they did a subgroup analysis, and these risks were even present in young people, even in those who didn't have any underlying health factors and didn't really have any ongoing particular risk. This is another one showing that there's an increased incidence of a very specific type of ST elevation myocardial infarction that we're seeing in patients called MNOCA. This is another study looking at almost 3 million patients across 300 hospitals across 3 European countries, also showing that there's increased cardiovascular risks. Sweden have had a look, and they again have demonstrated there's an increased risk of heart attack and stroke. This study here was looking at patients predominantly that had really mild acute symptoms with recovery. Some were even asymptomatic, and although the risks weren't as high in those that were symptomatic, even in the asymptomatic individuals who were picked up on routine testing, the risks of cardiovascular complications were still there. This is a paper by Ike Nagal's group that has demonstrated that there may be subclinical myocardial inflammation in individuals with ongoing, quite kind of not that significant symptoms. And this is from the UK, which has just been published only a few weeks ago, looking at our own UK biobank, and again demonstrating that the risk of death following COVID from cardiovascular complications and others is much higher in hospitalised patients, but even in non-hospitalised mild COVID, and I really don't like the term mild COVID because we have no idea what the long-term consequences are. We need to get away from this narrative, but the risk was of all-cause mortality was 10 times more than in uninfected controls. We know from recent publications that reinfection increases your risk both of developing long COVID, but also of developing cardiovascular complications, neurological complications, GI complications, endocrine complications. And this paper shows that even vaccination, although it's great and it's done amazingly well at reducing the acute death rate and protecting us to a degree, this study suggested that vaccination only reduced your risk of developing long COVID by about 15%. Now, other studies have shown higher than that. So it does suggest that we are seeing a lot of cardiovascular complications. Vaccination is only partly protecting us from that, and we probably need to be thinking about putting in other sensible mitigations. So 2.5 years into the pandemic, the documented risks that we know of so far is that if you've had COVID, you are at increased risk of acute coronary syndrome, heart attack, cardiomyopathy, heart failure, atrial flutter, postural orthostatic tachycardia syndrome, pericarditis, pulmonary embolus, stroke, TIA, and others. But going forward, to answer Benita's question in the longer term, so that's the stuff we know about, but what's going to happen in the longer term? Well, nobody knows that because it's not happened yet. But we can give an educated guess, and it's not just a guess, it's based on science. We know now from lots of publications that COVID causes endothelial damage, which is inflammation of the lining of the blood vessels. It does this by direct viral invasion, it does it mediated through cytokines. Why is this worrying to us as cardiologists? So this is just a slide to show that endothelial dysfunction there's been lots of publications demonstrating this now. Well, it's worrying because endothelial dysfunction we now know is a major player in the development of long COVID, but also, and we've known this for many years, that endothelial dysfunction or endothelial damage is the precursor event that causes the ongoing development of a disease process called atherosclerosis. Now, that is the disease process that causes cardiovascular disease. So acutely, endothelial dysfunction causes your platelet activation and your clotting and your thrombotic risks. But in the longer term, it causes your foam cells, your cholesterol plaque disease, your hardening of the arteries, and your heart attack, strokes, and vascular dementia mediated through a different mechanism. So I guess to summarise, SARS-CoV-2 is not and never has been just a cold. I'm delighted to see that the acute death rates are going down. I kind of feel like we've got a new pandemic of long COVID. There's 150 million people now disabled by this illness. There's clear evidence now of cardiovascular and thrombotic complications in acute COVID. There is clear evidence now from multiple research papers looking at the health records of millions of people of cardiovascular and thrombotic complications in the medium term of the 2.5 years that we have managed to study this. But there may be, and I hope I'm wrong, but there may be significant longer term cardiovascular complications mediated via endothelial dysfunction. And really, this area needs some urgent research. And it needs urgent research because we need to know, is everybody who gets infected with SARS-CoV-2 developing endothelial dysfunction or not? And we don't know that yet. But we also need to know, if they are, over time, does that endothelial damage heal by itself or not? Because the worst case scenario is if everybody's getting endothelial damage to their inner blood vessels and it's not healing by itself, and we know that's the precursor to cardiovascular disease mediated via atherosclerosis, and we now know that 626 million people have been infected with SARS-CoV-2 around the globe, then I think there is a concern that we may see a tsunami of cardiovascular disease over the next few decades if we do nothing.
I'm going to stop you there just so we definitely have time for our public questions, but I know